We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date, in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we have got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world, actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we are now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology.
This child presented to us at 8 years of age with history of tetany, carpopedal spasm, and multiple episodes of seizures. These episodes had started at 2.5 years of age. The first episode was encountered following an acute febrile illness, during which the child developed episode of seizure. He was treated as a case of febrile seizure, received multiple antiepileptics, but remained refractory. The seizures remained refractory to management, following which a calcium level was done, which revealed hypocalcemia, and the child received IV calcium. Similar recurrent episodes were noticed during episodes of fever, according to the parents. And for these complaints, he received a long-term duration of oral calcium and vitamin D supplements. And yet, with febrile episodes, the child kept going into tetany, requiring IV calcium administration. The parents also gave a very classical history of recurrent oral candidiasis since about early infancy, about 8 to 10 months of age. The child was born at term with a weight of 3 kgs and had a smooth perinatal transition, had initially mild motor delay to begin with, but had caught up with the milestones. He was immunized for age. Now, the interesting part of the history comes with the family one. The parents were married within the same caste, but not closely blood related. There was history of similar complaints of hypocalcemia in maternal uncle who passed away at about 3 to 4 years of age. This was the index child was first born to this couple, and there was history later on of similar complaints developing in the younger sibling. I will elaborate on the rest of the family history as I move on to the course. There was no history of failure to thrive, no suck cycle to begin with, no other infections other than the candidiasis that the child frequently had. No episodes of frequent colic pain, poor appetite or nausea, no bony deformities as such, and no opacities noticed in the eyes. On examination, this child at 8 years of age had a fair height and weight. He had an SMR of TV stage TV2 CC bilaterally and pubic hair stage 1, had oral candidiasis on examination and dystrophic nails suggestive of onychomycosis. He had a positive Chvostek and Trosso sign on examination. There was no cataract, no dental abnormalities, no lumps or bumps suggesting an ectopic calcification, no hyperpigmentation, and no evidence of dehydration was noticed. So if we summarize the case, the predominant features that are coming out are refractory hypocalcemia, or if I say recurrent hypocalcemia, oral candidiasis, and nail dystrophy. If you summarize this is Potter case, you will think of APES or APS1 here. Theoretic possibility of George may be considered in view of early onset hypocalcemia and fungal infection, which will suggest a T cell defect. However, these children often have much younger age of onset, will have classical syndromic features. So, I'm sorry. So, if we, APS1 is an extremely rare disorder. Even in the high-risk groups, the prevalence is about 1 in 25,000, and the estimated prevalence in or incidence in USA is about 1 in 1 lakh. The age at manifestation varies from 0.2 to 18 years, with the mean age at diagnosis being 7.5 years, which is, I'd say, really sad because the presentations start much early. It is inherited in an autosomal recessive manner or in a dominant negative fashion. And because of this kind of inheritance, there is no gender preponderance seen with this condition. The basic pathophysiology in APS1 is a loss of function mutation in the AIRE1 gene, which is responsible for central immune tolerance. As a result, autoreactive T cells spread out to the circulation and infiltrate all the other organs, and therefore cause autoimmune destruction of these rest of the organs. Now, these manifestations may be endocrine or non-endocrine. Common endocrine manifestations include involvement of the thyroid and parathyroid glands, adrenal glands, pancreas, and the gonads. Common involvement of the extra endocrine manifestations, if I may say, are dental enamel, nails and skin, intestines, the salivary glands, liver, lungs, and the kidneys. Whenever you have a T cell defect, you will also have a B cell defect resulting in autoantibodies. So the common endocrine autoantibodies that you may encounter in children with APS1 are antibodies to the calcium sensing receptor, anti-TPO antibodies, antibodies to 21 hydroxylase enzyme, the GAD65, IA2, and ICA antibodies, which may help predict the occurrence of type 1 diabetes in these children. The classic pathognomic or the, if I may say, diagnostic antibodies are the immunoglobulin G to interferon omega. So the workup in the index child revealed hypocalcemia, hypophosphatemia with borderline low magnesium and a normal creatinine level. So if you go by the algorithm, hypocalcemia, high phosphorus, if your creatinine is normal, you look at the PTH levels. Now PTH levels were low for the level of calcium here. So this points to hyperparathyroidism. As we were considering the possibility of APS1, we went ahead with screening for adrenal insufficiency, which we got normal electrolytes and cortisol levels, and thyroid function tests were normal. So now we have established that this was hyperparathyroidism. And the urine calcium creatinine ratio was slightly on the higher side, 0.14. With all these manifestations, we went ahead, and the positive family history, we went ahead with genetic workup in this child, which revealed an autosomal recessive AIRE1 gene mutation, which corresponded to the clinical picture of this child. Now we need to know what made the diagnostic delay in this particular child. So if you look at the guidelines for diagnosis of chronic mucocutaneous candidiasis, such children need to be screened for endocrine disorders based on clinical setting, especially for AIRE gene mutation when you have patient sibling affected with the same disorder. Also, the guidelines for management and diagnosis of hypoparathyroidism suggest that if you have an early onset hypoparathyroidism with a positive family history and the occurrence of recurrent candidiasis, do suspect APS1. Had the individual picture not been seen and the child seen as a whole with candidiasis and hypoparathyroidism, the diagnosis could have been made much earlier, maybe as early as the first episode of hypocalcemia that the child presented with. Now, understanding the management of APS1. So, the three classical manifestations are the hypoparathyroidism, mucocutaneous candidiasis, and adrenal insufficiency. For management of hypoparathyroidism, you give high doses of calcium and activated vitamin D to these patients. You monitor their calcium creatine ratio so that they don't go into hypercalciuria, developing nephrocalcinosis and CKD. And if the phosphorus levels are high, you need to give phosphate binders there. For mucocutaneous candidiasis, each episode must be aggressively treated with azoles, and if refractory, caspofungin needs to be given. If these episodes are frequent, more than 3 to 4 episodes per year, an antifungal prophylaxis in form of amphotericin B solution as a swish and swallow needs to be given. If not treated aggressively, these children develop an increased risk of digestive tract squamous cell carcinomas. Adrenal insufficiency needs to be, before management, you first need, because it is a later manifestation, you need to screen for adrenal insufficiency regularly in these children. The first manifestation of adrenal insufficiency will be a decreased requirement of calcium and calcitriol. Management will include hydrocortisone and fluorocortisone replacement, and one needs to monitor serum electrolytes in these children. So management of the index case for hypoparathyroidism, the child received calcium and calcitriol supplements slightly on the higher side. Even with these supplements, the child developed recurrent episodes of hypocalcemia requiring admission for IV calcium administration. Now, the target or the goals of treatment for hypoparathyroidism is that you prevent hypocalcemic crisis while balancing that the child does not have hypercalciuria and prevent the risk of CKD. So the calcium targets are usually on the low normal range. And on follow-up, we found that the calcium creatinine ratio had risen to 0.34. However, ultrasound had not shown nephrocalcinosis at serial follow-up. Challenges with managing hypoparathyroidism, although clinically and biochemically, hypoparathyroidism in APS is not very different from any other cause of hypoparathyroidism. Multiple case reports have been published which describe an increased requirement of calcium and calcitriol during acute illnesses. To quote one of those case reports, this is recalcitrant hypocalcemia in autoimmune enteropathy. So this was a 14-year-old patient. During episodes of diarrhea, it became difficult to maintain his ionized calcium despite high doses of calcitriol and calcium. Moreover, with increased calcitriol doses and ongoing hypocalcemia, the phosphate levels increased, which made the management more difficult. So what makes APS1 hypoparathyroidism different from the others is the involvement of so many other non-endocrine organs simultaneously. Chronic diarrhea and malabsorption occurring as a part of the APS1 syndrome predisposes to bacterial overgrowth, celiac disease, intestinal infections, and pancreatic exocrine insufficiency. Hypocalcemia, as we know, is an enzyme. It's a part of multiple enzymes as well. So hypocalcemia per se also causes malabsorption through reduction of cholecystokinin, decreased gallbladder emptying, and pancreatic insufficiency. Although adrenal insufficiency had not developed in our patient, but in those that have them, glucocorticoids reduce intestinal and renal calcium absorption, especially when recurrent stress doses are needed, high dose of glucocorticoids are given, the calcium absorption further decreases. And this is what increases the calcium requirements during acute episodes in these children. So, when you know the primary pathology is hypoparathyroidism, do you think PTH is a superior therapy to what we are providing in these children? The problems with conventional therapy is that it is basically a symptomatic management. If it's hypocalcemia, you give up, you end up giving calcium and calcitriol. When you develop hypophosphatemia, you end up giving phosphate binders. It will not reduce your risk of hypercalciuria. Ectopic calcifications may keep happening in calcium calcitriol therapy. So these problems remain, and that is why correcting the primary pathology was considered to be something that under research. However, one is also aware of the long-term negative role of PTH, especially on growing bones. So there were multiple studies, and the one with longest duration of follow-up was this one. It looked at 14 children, 5 with APS1 and 9 with calcium sensing receptor defect, and the role of PTH in them over a period of 1.5 to 10 years. What it found was with conventional therapy, most of these children, most of these children had a low normal calcium, serum calcium range, but the urine calcium was significantly on the higher side. Whereas with the PTH therapy, while the serum calcium came down, the urine calcium also came down. So it was just a shift in the calcium range that we see here. Low serum calcium, low excretion of calcium in the urine. However, there was no mention of if switching to PTH therapy also increased the episodes of hypocalcemic manifestations in these children. It does establish safety over a duration of 10 years. So we do look forward to how PTH fares, and we will need more such trials to establish its safety. But yes, this remains a theoretical possibility of management for these children in future. Moving on to the index case, for chronic mucocutaneous candidiasis, the child had intermittent episodes which were treated with azoles and never required any more aggressive management. Growth was tracked serially and targeted well as per familial targets. The child fared well as per puberty as well. At the last visit, he was about 15 years, 8 months of age and had a testicular volume of 15 ml bilaterally with pH stage 5. We have been serially screening him for adrenal insufficiency and have found no evidence. His liver functions have been normal to date. Now, something interesting that happened in the last visit was that the parents told us that the younger sibling had developed recurrent episodes of cough and was on beta agonist. That is when we found out that even this child had had episodes of cough which were managed as hyperreactive airway disease, and the child had received beta agonists with inhaled corticosteroids. Now, why is this important? Because these children may have autoimmune pneumonitis, which mimics a hyperreactive airway disease. So there was one chest X-ray available which was normal, but then again, if the child has recurrent episodes, we need to get a CT done to rule out bronchiectasis. We had planned a CT, but the child has not come back so far. For the other manifestations, we've been screening him and they've been normal so far. Now, a brief description of the course in sibling. The sibling had similar episode of mucocutaneous candidiasis onset at 6 months. He developed hypocalcemic manifestations at 2.5 years of age, and that is when the parents came to us. The second child has developed similar complaints. Again, the genetic mutation was also done in the younger sibling and showed the same mutation. And it was the lung manifestation of this younger sibling that brought us the history of similar complaint in the elder sibling. Other functions have been tested in the younger sibling and have been normal so far. There is a maternal nephew, mother's nephew at 6 months of age developed chronic mucocutaneous candidiasis, and this child was finally picked up at the right time and found to have the same mutation. So the messages I would like to impart from this case are that if you have a child with chronic mucocutaneous candidiasis, this may be the earliest manifestation of APS1. Look at the family history, screen for endocrine disorders, and if positive family history is seen, do test these children early before they go into hypocalcemic crisis. Early genetic screening should also be offered to siblings and family when one case is already diagnosed. An aggressive treatment of mucocutaneous candidiasis will help prevention of squamous cell carcinoma later on. The most important thing that I want to highlight with this case is that these children, during acute episodes of infection or a flare, may need higher doses of calcium and calcitriol and do well with that. Regular screening is required for associated condition and manifestation.